Hello. Today, we have an amazing episode for you. We have as our guest Dr. Cassandra Thiel. We're going to be talking about the intersection of healthcare and sustainability. And we're going to dive into how sustainability is perceived within the industry. Also, how policies and procedures can either block or slow down the adoption of sustainable practices. And what barriers, either real or perceived, people within the industry find to be able to adopt those practices, and how Dr. Thiel deals with them. This episode is full of great insights. So let's get started. Hello and welcome to Roots of Sustainable Impact. I'm your host, Eloisa Marquez Gonzalez, and today we're going to dive into the intersection of healthcare and sustainability. And for that, I'm very excited to welcome to the show Dr. Cassandra Thiel. Hello, Cassandra. How are you?
Hello, Eloise. I'm doing really well. It's really great to be on your show.
Thank you for joining us today. And today we're going to be talking about healthcare and how do we make data-driven decisions to drive sustainability in the healthcare systems. So, but before we go into that, why don't you tell us a little bit about yourself for those folks that have not yet met you?
Yeah. So, hi, everyone. I'm Cassie Thiel, or Dr. Cassandra Thiel, whichever you prefer. I am an assistant professor at NYU Langone Health in the departments of population health and ophthalmology. I also have an appointment in engineering because I have a background in engineering. And I own a consulting business, clinically sustainable consulting. And that's how Eloise and I met, was working through this consulting business in the sustainability world. But my work, coming from the engineering background, I look at sustainability holistically and particularly in the healthcare space. So back when I was a PhD student, I met a surgeon who was really upset about how much garbage she could make in her procedures. That, she'd be really sustainable at home, but she'd go to work and do a surgery and turn around and there'd be a mountain of garbage. And she's there to protect health, right? To improve the health of people. And she knows that this level of consumption and the waste that's produced is not helping people. Like, she might be helping that patient right in front of her, but overall there's something kind of wrong with the system. And after having a chat with her, I introduced her, Noe Copley-Woods, to my advisor, Melissa Billick, and that launched some really interesting research projects in obstetrics and gynecology. And my first time in an operating room, I thought, man, this place needs help. There's so much improvement that can be made without impacting patient care, right? We can keep that value high for the patient, but really improve things for all of our public health. And so that was how I got started on this journey, and I wanted to stick with it. And somehow I'm still here working on healthcare sustainability. So that's my background.
That's awesome. Thank you for that journey, explaining the journey on how you got to sustainability, because your background is on civil engineering. Am I correct?
Yep. Civil and environmental engineering.
And got into healthcare. So you bring a breadth of experience from many different perspectives into the sustainability world. And
yes.
So from all your experience in healthcare, how have you seen, is there any shift happening within healthcare on how they view sustainability? What is your take?
Yeah, I think there's definitely a shift. So I started this work, I finished my PhD about 10 years ago, over 10 years ago. And about 10 to 15 years ago, when I was really getting started in this, there were still, the clinicians I talked to, nurses, doctors, anyone working in a healthcare facility would be interested and intrigued, but they'd really be like, why are you doing this? Or, good luck. Like, that was kind of the attitude. They weren't necessarily negative about it, but they weren't like, yeah, we need to do something. And that is a shift I've seen over the last 10 years, that now a lot of these healthcare professionals are saying this is impacting public health, our health, right? That, we just had the wildfires out in LA, and we've been seeing those kinds of impacts now year on year. Healthcare facilities are struggling to stay open with things like hurricanes and fires and supply shortages that are caused by these supply chain disruptions from climate change. And we're starting to see those effects of climate change on our patients. I'm not a clinician, but, people who's actually directly serving patients see that their patients are impacted by climate change. And then they draw that connection to their workplace and say, we can do much better here. Mm-hmm. And so now I think the attitude amongst healthcare professionals is we need to do something about this. A lot of them are focused more on maybe adaptation, like we need to help our patients get through these events. But some of them are really looking critically at their healthcare systems and saying, this isn't quite right. Like we can do better here. And they're trying to work on that mitigation piece. Like how do we reduce our consumption and reduce our footprint and basically make healthcare more efficient? And that works on a variety of perspectives, not just environmental, but it also has financial implications that are actually positive for healthcare systems.
I agree. I completely agree with that. And to your point, what I have heard in conversations that panels that I have attended here, it's physicians mention on how patients come in, they get that treatment, but then we're sending them back out to the environment that made them sick to start with. So yeah, that is very interesting. And so when you go into these organizations, what is the state? What's the state of the land, the lay of the land? Are there any frustrations that you have when you walk in?
Oh my!
Rhetorical question.
No, it's beautiful and lovely, and everything's smooth.
That's why you're there.
Yeah, there are certainly a lot of challenges in this space, and it's different, right? So. I've worked in a lot of different places all around the world, and there are actually a lot of examples globally of doing healthcare really efficiently. Mm-hmm. So some of my early work after my PhD, my postdoctoral work, I had a Fulbright fellowship and I went to India, and I was working with an eye care institution in southern India called Aravind Eye Care System. And they're really built around efficiency. They're basically made a factory, an assembly line out of cataract care. And by doing so, they have really excellent outcomes, very low resource use, and really low costs for the patients. So they're able to charge at that time, it's about 10 years ago now, about $250 an eye was to treat a cataract. Where here in the US it was $3,500 an eye.
Wow.
So huge price differential, and they're trying to address these patient needs for patients who are making very little income, right? They might be living off of $1 a day, mm-hmm. and they can't afford to treat their cataracts at US rates for certain. Yeah. And so they kind of had an interesting model where they asked patients to pay whatever they felt up to the market rate. And a lot of patients would be free or reduced service, but about 1/3 of patients who paid for the surgery at the market rate covered everyone. And they were able to do that because they set it up like a factory and because they were really efficient with their resources. So I'd gone there using tools called life cycle assessment and carbon footprinting tools to really look at the environmental footprint of their procedures. And we found that their cataract surgery generated, I think it was about 5% of the carbon emissions compared to the exact same approach in the United Kingdom. And it was because they used so few materials. It was all reusable. And they were really careful about that stuff because that adds to the cost for the patients. Like they didn't necessarily care about the environmental impacts when they started, right? They were thinking about the financials. And it ended up being a really efficient system. And we see that those kinds of things exist all around the world where there is a little bit more resource scarcity or where you're trying to meet a price point that, is a little tougher. Mm-hmm. And in the US, our healthcare system in general is just really complicated and weird. And who's paying for healthcare is an eternal question. We know it's not working well for everyday people. Right. But we have all these individual insurance plans. So there's no single payer like there is in a lot of other countries. And our healthcare system, because of that financial model, is a little abstracted from actually protecting people's health. Like we're a sick care system, right? People mm-hmm. get paid for treating sickness, not for keeping people healthy. And that is kind of a toxic dynamic that's hard to overcome. And it's not like clinicians are saying, oh, I need you to be unhealthy and I need treatment, right? Clinicians don't think that way. But at an administrative level, when you get these large healthcare systems, there is some of that element. And the way that money flows through the systems means that we're not prioritizing public health. We're not prioritizing some of those, upstream interventions that would prevent more catastrophic care. Mm-hmm. And so we end up kind of channeling a lot of patients into like I don't know, spinal surgery when they could have done something else to avoid that high intensity treatment that's really high cost that may be less effective than some of these catching it early kinds of things. So this is to say, when I go into a U.S. healthcare system, there's a lot of barriers to changing the way that things are done. And some of it is I would love to see things move to that more preventative kind of approach, but that's just not how the funding model is structured. Like primary care doesn't get a lot of funding, public health doesn't get a lot of funding, and it certainly gets a lot of flack with the current administration especially. Whereas some of these, surgery intensive kind of approaches do get a lot of funding. So health systems naturally try to funnel more people that way. And I work a lot with surgeries because they have a really high intensity. They use a lot of energy, a lot of supplies. And so we look in those spaces to see how we can improve things. Because even if we get better at their prevention, we're still going to need those treatment pathways, right?
Correct.
And so we're trying to figure out how to make those things better. And even when you dig into that at a detailed layer, there's so many players in the space. And because the system hasn't really been thinking about sustainability or thinking even about cost containment that much, there's a lot of opportunity, but there's also a lot of interesting resistance. So through my consulting work, I'm trying to reach a lot more of those product manufacturers and supply chain, like the groups and organizations that are really contributing to a healthcare system's footprint, but maybe haven't engaged in sustainability work at all because they just haven't thought about it, right? That those frameworks for thinking about sustainability and building better products exist in other industries, but not so much in the healthcare system. And partially that's because we've said, healthcare is so important, we don't want to make it bad. And so people haven't thought about it. But now there's suddenly this influx of clinicians saying, we need to do better. And that's making everyone else in this whole ecosystem think about what they need to do to contribute to that.
Yes, that is so interesting. And that resistance that you talked about, it has to do also with the incentives, because as you said, the way that the money flows, everything is incentivizing sick treatments.
It is.
And unfortunately, it's we have to go upstream, and also with the regulations, because it's a very regulated industry. So how do you deal with those regulations? Because many folks I have worked in the biotech and medtech, and they go, well, this is too complicated because we have so many regulations and so many things to take care of that just the sustainability piece doesn't fit as nicely.
Yeah, I hear that a lot. Yeah. I hear that excuse. I'm going to put it as an excuse a lot. Of like, there's a policy against this or there's regulations against this. And that's been an interesting one. So I'll tackle it from kind of two different perspectives, the provider perspective, and then let's maybe talk about manufacturer of medical surgical devices perspective. There's a lot of other perspectives you can take, but from the provider perspective, so a lot of my academic work has been with providers where I'll make friends with a clinician in a certain specialty, and they'll be like, I want to know the footprint of my surgery that I specialize in, like cataract surgery or hysterectomy in the case of NOE. And so I'll work with them and we'll design a study and we'll figure out where the emissions are coming from with that procedure. And like most places, right, the direct emissions are pretty small, and it's all those indirect emissions, the scope 3, if you will, like supply chain and waste management. Those are the larger portion of their emissions. And that may make sense, right? Yeah. And then when we talk to the clinicians about what they can do to make changes, oftentimes you can just apply the old reduce, reuse, recycle framework to it, right? There's a lot of bloat in healthcare, I'll say, where clinicians, especially in the US, will bring in a lot of extra products and supplies. Some of it's pushed on them by vendors and the product reps that they have in the hospital. But some of it is just because it's fun and cool and whatever. We're going to add more stuff to it because they don't think about necessarily the costs of all that. And so for most of the procedures that I've studied, we've done waste audits, right? We've dug through the trash and figured out what they're using and not using, what they're throwing away without using, which is somewhat frequent. And in surgeries, that unused supply bucket is actually surprisingly large. There's a study, I think, out of UCSF looking at neurosurgery and found like 15% of their supply costs were unused materials. And so there's just that, which is sad. And that's your reduction, right? Like, what do we actually need to perform this procedure or to care for this patient? And then you get rid of all the extra stuff that you don't actually need, right? There's that optimization approach. And then the next layer down would be getting more into circularity of like reusing. Which products can we switch to reusables, or can we use different things? Like there's reprocessed single-use devices now as an industry that's very safe and effective and cost-effective. And now we know it has a lower carbon footprint than using an original manufactured single-use device. So you're getting a little reuse out of a single-use product. And then you go into recycling, which is kind of lowest value typically in any sustainability realm. That's, of course, what everyone focuses on initially. Like, we'll recycle more because it's an easy solution. You don't have to change anything else about your process. You just change how you're throwing your waste out. And of course, what we're finding in our analyses is that doesn't really reduce your footprint that much. If it makes you feel better and it helps get people engaged, cool, go for it. But that's not a hot target area. Anyway, so we talked to clinicians about those, and particularly with the reuse kind of bucket, when we talk about changing what supplies they're getting in and, really trying to refine that, that's where clinicians get weird, where they start to say, oh, well, the Joint Commission, which is an organization that accredits hospitals, right? Mm-hmm. So they say it's a legit hospital, Medicare and Medicaid can pay them for services rendered. So when the Joint Commission's in a hospital, everyone freaks out and they want to make sure everything's perfect, right? Mm-hmm. They don't want to lose their accreditation. So they'll blame the Joint Commission, first off, for not being able to do sustainability stuff. They say, oh, the Joint Commission won't like that. We're not going to do it. The second point is they might just say it's policy. We can't reuse this item because it's against policy. And you try to dig in a little bit like, what policy? What's the regulation number on that? And they can't really tell you. Yep. And so after hearing this multiple years in a row, we finally started digging into this, and particularly in eye care. So I've done a lot of work in ophthalmology. Mm-hmm. And we have some studies that we're hoping to publish soon. We're submitting them to journals. But one of them was a legal review that was taken on by Temple University. They have a health policy law program. And so they assessed policies and regulations around single-use supplies and drugs for ophthalmology. And they couldn't find any federal regulation that would prohibit what we were talking about doing, like reusing some of these things. The closest they could come up with was, of course, FDA, the Federal Food and Drug Administration, mm-hmm. has regulations like they approve drugs or supplies for single-use or multi-use, and that's kind of it. Once that designation's there, that's how the hospital has to treat it. But for like multi-dosing of drugs, the bottle has to be labeled single use for that bottle to be disposed of between each patient, right? If it doesn't have single use on the bottle, you can use it multiple times, as long as you're following some manufacturer recommendations or a protocol around how you're reusing it and like mm-hmm. how you store it, those kinds of things, right? So the reason that pops up in ophthalmology is because when they're doing a cataract surgery, they put a lot of drops in your eyes. Okay. And they might have a 10 milliliter bottle and they'll put a couple drops in your eyes, which is nowhere near a milliliter. And then between the surgeries, they'll throw those bottles out. And so they generate a ton of waste of pretty valuable drugs just from doing these cataract surgeries. Whereas mm-hmm. at Aravind, this clinic in India, they are reusing those drops on multiple patients throughout the day until the bottle's empty. So they basically waste no drugs. And the reason this is so irritating, in addition to being, all the production that's now thrown away, is that there are shortages of some of these drugs in your doctor's eye clinic, right? So like dilating drops, they might have shortages of, and they're throwing them away constantly from an operating room. And when you see your optometrist to get your eyes checked, those are multi-dose bottles. It's the exact same drug. It's just that because it's in an operating room, we suddenly get weird about it. And so these are the kind of weird things. Anyway, to go back to Temple law, they found no federal issues with this. And then when they went state by state, there were some other issues around drugs, but nothing on supplies. The issues on drugs were that each state has a dispensing rule for pharmaceuticals, right? So if the drug doesn't have the patient's name on it, technically in some states, your doctor's not allowed to give it to you after your surgery. And so the way this plays out in cataract surgery is they put antibiotic drops in your eyes after your procedure. And again, couple drops from the bottle. And in some states, technically, that doctor or nurse is supposed to throw that bottle away. And then you, the patient, would have to go out to a pharmacy and buy the drug again to administer to yourself throughout the week, because they're not legally allowed to give you the bottle unless it has your name on it, because they're not a dispensary. And that's one of those things where you're just like, what? This is so dumb. So that was the one legal policy thing we found in this whole landscape. And I work with an eye sustainability group called Sustain, EYE Sustain. And they're trying to tackle this policy issue of these state pharmaceutical laws in the states where those are an issue. And so one of my colleagues, David Palmer's done some great work in Illinois on this, and like getting them to change their laws around dispensing of topical drugs. So anyway, long story short, what we found from that study was that there was very little hard regulation around like prohibiting some of these sustainability initiatives. And we took this study a step further, and we did really qualitative interviews with a bunch of people around our eye center at New York University. And this was frustratingly fascinating. The surgeons didn't have any problems with the sustainability initiatives we were pitching to them. We said, hey, why don't you, get rid of this disposable drape on the back table and just use the table and wipe it down between cases. And they're like, yeah, sounds good. The nurses and the scrub techs in the operating room said, ooh, that's a safety issue. Like, we might cause infections if we do that. We said, okay, we noted it. We were just looking at barriers and facilitators. We talked to our infection control officer, and he said, actually, I have no problems with that. That's already in our hospital policy that's equivalent. And you're like, what? So there's like a mental barrier for a lot of people. And that's kind of what Temple law was also referring to, is basically they call it folk law, that there's the way things are done. And people don't like to change that. And that's what they call it. But it's not policy.
We have always done it that way.
Exactly. And that is the hardest thing to overcome, I think, in this space.
Yeah. And it's a lot of, it's how you manage that changing of behavior. How do you walk them through the process to figure out that everything's going to be okay? Because sometimes what might be is that they feel maybe their job might be threatened. How is this going to change my job? That at the end of the day, that's a question that comes to mind. How am I going to explain to my loved ones what is happening when I don't understand it? So
yes. And I think in the healthcare space, the issue for a lot of these folks is that there's it's not universally true, but there's not a lot of top-down support for changing the way that things are done. Right. So there's not like an executive who says sustainability is a priority and everyone's going to commit to it. There are very few healthcare institutions who have that level of commitment. And so what you get instead is that ground level, grassroots kind of approach, where there's some passionate individuals who really want to change things. But if they make a mistake, the healthcare system as a whole is very punitive. And, they love their lawyers and litigation. Yeah. And no one wants to take that risk of their jobs by changing one little thing in their surgeries, right? And so I think that's one of the major barriers in a practical sense, is that unless you get that institutional support and buy-in to really move some of these things forward, you can't rely on these individuals at the ground level to voluntarily try to make these changes. You have to have that top-down support of those initiatives.
Yes. And in my experience, that applies to pretty much every industry. If you don't have that top-down support, your initiatives many times fail, especially in the private sector. It's very important for leaders to be vocal and to show up. Because I also seen I very much support it, but you go and tell them. But can you voice it? Oh, no. Have someone else do it. It doesn't work. Yeah.
And I think you have different levels of executive support, where you have the executive who maybe like doesn't get in the way. And that's like, okay, low bar, but okay. Yeah. And then you have the ones who actually like try to like build it into the strategy or the mission of the organization, and then align like promotion and tenure, whatever, with some sustainability goals. Like, not saying all of them have to be there, but that is some part of everyone's job description and promotion. Like that's really what moves this ahead.
Yes, absolutely. Absolutely. And so you mentioned before, we talked about providers and then also manufacturers. So I had a pin here on manufacturers.
Yeah.
I also want to ask you, for providers and individuals, giving them the tools, we're talking about data-driven approach. How can we give them the tools? So I think we can go two routes or many routes. I will give you which way do you want to take it? Do you want to go through manufacturers, or do we stick with providers?
I think we could talk about providers and tools because this gets into the manufacturing realm very quickly.
Perfect. All right, let's do it.
Yeah. So a lot of the work I've done so far, again, life cycle assessments of procedures, and they're fine, but it's really hard to do those things. It takes a long time.
Can I interrupt you for a second?
Oh, sure.
For my listeners that might not be familiar with life cycle assessments, could you give us a quick description of what that is?
Yes,
please.
Yes, I can. So a life cycle assessment is a tool that we use to quantify the emissions of a product or process across its life cycle. So everything around you, the phone you're listening to this through, like the car you're driving in, whatever it is, everything around you has a life cycle. Put cycle in quotes there, where we extract raw materials from the earth, right? We're mining for oil, we're digging out wood, I don't know, whatever it is we're doing, we're extracting all these raw materials. Those things get shipped all around the world to a bunch of factories where they get manufactured into products and then shipped all around the world again to wherever we use them. So it could be a healthcare facility, it could be your home. And then we use those things. And then pretty much when we're done, we discard them. So they end up in a landfill or incinerator. And you can see product life cycles are pretty linear, which is one problem in and of itself. But what a life cycle assessment does is it takes each of those life cycle stages and says, okay, here's what we needed to make that thing happen. And here are the emissions associated with each of those stages. So you might be burning fossil fuel, leading to greenhouse gas emissions to air, but you can look at emissions to water and soil as well, and not just greenhouse gases, but things like particulate matter and air pollution, or water pollution that causes dead zones in the Gulf of Mexico, for example. Well, I'm going to keep calling it the Gulf of Mexico. Anyway. So life cycle assessment takes all those emissions across the life cycle and it sums them all up and it groups them into categories like a carbon footprint or greenhouse gas footprint. And it makes it a little bit more digestible. And life cycle assessment has been around for about 50 years now. It's got some standardization through the International Organization for Standardization, ISO. And companies use it a lot of the time to develop a footprint for a product that they have. And that allows them to make claims on that product that it's greener than other things because they actually have data to support that claim. And this is heavily used in Europe, and it's going to expand massively because now the European Union has basically mandated that anyone who's making an environmental claim has to have life cycle data on that product. And in the US, we're seeing it more sometimes with the Trade Commission. It comes up as an issue where there's been a little bit of litigation for companies who make greenwashing claims essentially and don't have this information. But if you have an LCA, you can support your claims with that LCA, and that's enough to protect you legally. So that's one of the impetus for companies to start doing it. We like using it in the healthcare space at this procedure level, right? If I look at a surgery, because it helps me identify what components of the surgery are causing the biggest emissions. And I can still use it at a product level to say, do I want reusable or disposable? And I can do an LCA and say, okay, in general, the reusables look better from an environmental perspective. And this is actually true. Like most of the LCAs done on reusable versus disposable devices show the reusables better. Sometimes the water categories are worse for the reusable, right? We're emitting more to water. And so those can end up looking a little bit worse, but we can look at a range of different emissions and start comparing these things more easily. So that's where life cycle assessment's very valuable. It helps you squash out greenwashing, figure out how to improve your process or your product, because it helps you pinpoint those things. And it helps consumers compare products then too. And we've started applying this to the healthcare space. And we got some really interesting things going on. There's, for people who really want to dig into this, there's a website called healthcarelca.com. And it's one of my favorite websites. They've basically scraped the internet for every life cycle assessment related to healthcare. And so you can go in there and see everything that exists so far. So it's a beautiful literature summary.
We'll add a link to that on the show notes.
It's a great show notes piece. But what we're actually seeing is like we've had this huge growth of LCAs in the healthcare sector, but there's still very little known in this space. You know, like the green building industry has been doing LCAs for ages, and it's pretty well integrated into that space. We're babies in this space. We don't really know what we're doing yet. And so as we're growing here, we want more data. Healthcare systems who are really committed to this, they have decarbonization goals, even for scope 3, like they have procurement goals. So Kaiser Permanente, one of the largest health systems on the West Coast there, they have scope 3 emissions reductions goals that they're trying to achieve. And that means that they need information from suppliers and manufacturers about the footprint of their products. And suppliers and manufacturers are not ready to give that information over because they're new to this space. And some of these suppliers, you think about the major ones, 3M, Medline, Stryker, like there's a lot of really large healthcare manufacturers. They have thousands, tens of thousands of product SKUs, product lines. And to do a life cycle assessment of each one of those is unfathomable in some ways. Artificial intelligence is making this interesting. It's kind of changing the dynamics, but it's hard to get that much environmental data out that quickly, especially when you don't have a system in place to start monitoring it, anyway.
Yep.
And so that's one of the big struggles in the space right now is how do we provide data? Like healthcare systems, the providers are trying to measure their scope 3 emissions and they don't have great data for it. We're using financial models, which are not my favorite, especially in healthcare, especially in US healthcare. Like for some reason, the carbon footprint of our drugs are so much higher than the carbon footprint of Canada's drugs. So our financial models are not my favorite, and they don't make for great managerial decision making, but that's what we have to use at a healthcare system level because you can't do anything else at this moment. And for the suppliers who are being asked for these things, we don't yet have standards. I know BSI, British Standards Institute, and there's a couple other ones are working on standards development in this space, but we don't have them yet. And so, it's kind of a chicken and an egg thing where each health system is asking each supplier for a bunch of different environmental information. And so the suppliers have to deal with all this influx of like requests for info that they may not have and may not even be relevant for their products. And it's just a lot of work that's maybe not driving the actual goal forward yet.
Right.
And we're kind of in this gray spot of like trying to hash through this and figure this out. Like, how do we make it easier for suppliers to provide information without greenwashing? And how do we make it easier for healthcare systems to better understand what things they can leverage and change about this whole industry?
Yes, this is fascinating. I love what you said. Well, I don't love it about the systems, but I truly empathize with the systems because, and that's what drives greenwashing. The fact that manufacturers are being pressured to provide this data, and then they start trying to scramble on how do we get the data. And they come up with a number and they put it out there. And then it's greenwashing. My question to them is like, how do you get this data? It's like, well, in our systems, we just went in. But when did you implement your system? 10 years ago or 5 years ago, even 2 years ago, you didn't have these data points. You had no idea that you were going to be asked these data points. So how did you actually get them? So it's a whole infrastructure that is required to be able to get that data and to be able to claim whatever is that your product is. So it is. And if
you set up that system internally, it actually is not it's still not easy, but it's not so challenging to produce at least life cycle data, maybe not a full life cycle assessment of every product, but you can start really churning these things out quickly if you have a system in place to do it.
Correct.
And that's what people are lacking in most of these companies.
It's that adaptability of being able to say, well, we need this information. How do we go back and how do we get it into our own internal cycle of improving our systems and our processes? That's when you add it into the way that you work. So having that's where the organizational adaptability comes into play. And some organizations are very rigid. And yes, we look at our systems or our process every 2 years. It's like, well, that's too late.
Yeah. Ideally, you're not just doing life cycle assessments for reporting purposes. You're hopefully integrating them into your product design and your strategy as a company. And, it should be informing what you're actually doing, right? The goal here is to improve, to change the industry so that it is environmentally better. And I think there's certainly a lot of industries that I've seen, or a lot of companies within this space that are still just like, we want to just report. We want to try to get our market share. And it's like that's so myopic in thinking. Like you got to think broadly here. This is an opportunity for immense creativity. And that is a better market approach in my mind than just like, how do we just do the bare minimum here?
Correct. Because it gives so much insight on using better products, given your customers, either your patients or your own employees, better experiences. So there's, as you said, there's an infinite ways that you can improve just by understanding that life cycle assessment for your products and your whole operation. So are there any metrics that if they have the life cycle assessment, or even if they don't, let's start with, if they have a life cycle assessment, are there any metrics that you will say, keep an eye on this? There are any metrics, KPIs in general?
Yeah, I think that the KPI space is still up in the air as far as it's not like, it hasn't shaken out to like, these are the ones that most institutions work on. I think, so for a long time, we've maybe started with these kind of preliminary metrics. So a lot of healthcare systems have like waste reduction and diversion goals, right, to get rid of their medical waste. Some of that ends up pushing them a little bit upstream, but a lot of it is really more like, how do we do better sorting rather than how do we stop bringing in so much garbage? That's a different issue. Yeah. And some of the other things are around greenhouse gas emissions, and depending on how they're monitoring it, they might set a goal like 30% reduction by 2030 might be a little bit fast, but they might say 2030. So they might be starting those kinds of targets. For manufacturers, this is an interesting one. And I don't think I've seen a lot of like corporate level KPIs related to sustainability yet in this space. It'd be nice if you said like 30% of our product lines will use renewable resources by whatever day, but I have not seen those kinds of KPIs emerge yet. They might start having some language emerging around sustainability, but I think a lot of them are still new to this space. And so they're really focused on solely greenhouse gases and not necessarily thinking about the broader range of sustainability options that can help them achieve their greenhouse gas reductions goals, but are much more comprehensive and long-term kind of solutions. So like getting into circularity, right? So we talked about linear supply chains. There's this whole field of probably philosophy and research, and it's a giant field. Yeah. Looking into circularity of products. And right now, the primary mode of operation in healthcare is linearity. There is so much single-use disposable stuff in US healthcare, and that the elements of circularity are really narrowly focused on things like recycling. And so if you're a single-use device manufacturer, the few that I've seen kind of even talking about this space are like, oh, we offer a recycling program. We have a recycling partner who will take our device and recycle it. And I put that in air quotes because I think those of us who are sustainability specialists know that especially the plastics recycling market is kind of crap. It doesn't usually work all that well, and it ends up probably being worse for the environment and for people than just having thrown something away in your local landfill. And so I have a lot of questions about that. And most of these device manufacturers are still using virgin plastics everywhere, even in packaging and stuff. Like they just refuse to entertain the idea of alternative non-virgin, feedstocks. And in my mind, if you're talking about a recycling program, you have to start talking about how you're going to use recycled content, because otherwise you're not actually making any solutions here, right?
Right.
And that's kind of where this industry is at the moment. They're still in the really nascent early stages of like, oh, we could recycle more. And like, that's nice. Let's keep digging in here. Let's keep brainstorming.
Yeah, we can put a pin on that one and let's keep moving.
It's a nice idea. Let's move through that one to the next one.
Correct. Because otherwise you're just pushing the issue downstream and keep fitting.
And you haven't changed the fact that you're relying on fossil fuels, you're extracting all these resources, you're polluting all these things upstream. All that pollution is still there, and you haven't solved that problem at all.
Yes. And from this, how does resiliency play into the reducing emissions?
Oh, it's huge, I think. This is where I think we could use more research to really talk firmly about those connections. But, I got to work through the pandemic, unfortunately. And when the pandemic was first hitting us, I'm at NYU, and that was one of the initially harder hit institutions, I'd say, for the pandemic. I mean, New York was kind of a hot spot in the early stages for the US. And anyway, I got called in fairly early on to start trying to calculate burn rates for PPE at NYU. And we pulled up a bunch of data and tried to look for correlations, like how could we even estimate what our burn rates were before the pandemic? Because PPE, personal protective equipment, is not something healthcare systems cared much about. They wanted to have it, right? But the supply chains were pretty robust, and it was a pretty cheap material, gowns and gloves and those kinds of things. So no one really cared about them. Like the week before the lockdowns, I could have gone into an operating room and like pulled on the little box of masks and said, oops, like the whole box fell on the floor. I'll just throw it all away. And the moment that pandemic hit, it was like, oh shoot, like we need that stuff. And we don't know how much we use, because healthcare systems are really behind the times with supply chain management, like 10 years behind other industries. They have no idea how much stuff they're using. Sometimes they don't even know how much they pay for their stuff. I've talked to healthcare systems where their chief financial officer couldn't tell me how much they spent on disposable supplies. It's amazing. Every healthcare system's run a little differently on that front, but for PPE in particular, it was not seen as a high value item. Like they clearly it was important, but no one thought it was important enough to track. Like, how much are we actually using? And are there, ways to forecast our needs? They never would forecast it, right? They just say like, this is roughly how much we need. And they'd have a 3-day stock on hand, because a lot of hospitals go with just in time delivery. So it's like really narrow stock supplies. And when the pandemic hit, most of the manufacturing for that stuff happens in China. Most of the raw materials are sourced in China. And China had already had, New Year's celebrations. So they were already on a shortage of production. And then the pandemic hit, and it was just a disaster for supply. Meanwhile, demand is spiking, because now everyone's using all the PPE for everything, instead of, how we were more triaged with it before. Right. And so it was just terrifying, really. Like, that's the only word I can use for it. And going through the data for the healthcare system, I mean, it still gives me the heebie-jeebies to look through those numbers. Like, we didn't run out of PPE, but we came very close, and we didn't know how much we actually needed at all. We couldn't even guess. We looked at, how many gowns were we using per patient, and the range across our different clinics and healthcare tertiary centers and whatnot was so huge. We couldn't even come up with a great number. It was like maybe 5 gowns per patient to 20 gowns per patient. Wow. Like, that's a huge range. And we didn't know. We couldn't tell from the data what was like consistent. And trying to predict what we would need was just nearly impossible. And so I think that, I think a lot of healthcare systems have forgotten about that. We like to block out what happened during the pandemic because it was pretty rough. Yes. But that was an eye-opener for, I think, a lot of different people. Like, we need to better know what we're using. And the thing is, there are reusable PPE options out there. We have like PAPRs and stuff are on the more reusable end of the spectrum for like masks, but gowns can be reusable. There's reusable isolation gowns, reusable surgical gowns. It's just that most institutions choose to use disposables, and there's a variety of excuses that they'll use for that. But I know anecdotally, talking to health systems that had reusable products, they were okay. They weren't great because we did increase the use of gowns and stuff, but they had their stock on hand. So they weren't like spending $1 million to ship a plane of PPE from China to New York just for them. They had their stock on hand. And that's why reusables add to resilience. You own that stuff. It's yours. It's in-house. And it just adds a layer of safety instead of depending on these stretched out global supply chains where there is a lot of fragility in it and you don't understand who you're all connected to in that supply chain, right? Like the manufacturers of the gowns don't even know who they're connected to down the supply chains. And it adds to that security. Another kind of layer to this, I like to point to the work of one of my colleagues in the UK. His name is Mahmood Buddha. And he's of Pakistani origins. And when he was back visiting his family, one of his cousins was like, "You're a surgeon. I'll take you to the factory where your surgical tools are manufactured." And when he got there, he was like, "Oh my God, there's like child labor violations, a whole bunch of labor violations in this factory, right? And this is where disposable surgical tools are manufactured." And so it's very clear, and this is National Health Services, but I'm 100% sure it's in every medical supply chain.
Correct.
There's labor violations throughout all this, and you don't have control over that if it's remote. And on top of the labor violations, one thing he had also noticed while he was in that factory was that these surgical tools, which are supposed to be sterile, were not being cleaned before they were being sterilized. And so these are like layers of things. But, you think about an ophthalmic surgery, you're doing an incision in someone's eye. It's got to be really precise. Yeah. And that blade might not have been cleaned before it was sterilized, meaning there could be debris left in your surgical field. It's not great. But if you have reusable supplies, you control how it's being reused, right? You control that whole process. And it's also local. Like it adds a little bit more security to the process and the procedure and have your stuff locally. And if we have all these little different local buckets, then if like a hurricane hits and knocks out a local branch, theoretically, you'd be able to stock that up better. It adds to that resilience. And I think there needs to be a lot more research done in this space, but reusables, I think, really, really help with that resilience piece because you're not reliant on these single-use, giant global supply chains where lots of little things could lead to this tiered effect of like not getting the things you need, not getting your supplies.
Correct. And what you bring up is very important of having your local vendors. It's very important for resiliency and also to your point of if something happens to the area, how do you continue to work? And that's where the business continuity and risk management comes along of having what's your secondary supply chain in a way. So this has been so insightful. And so Cassie, if do you have any advice for healthcare leaders that want to start implementing, integrating sustainability into their strategy more effectively? Any advice that you can give them? I know it's
so much advice. Contact me and I'll fill you in on everything.
The bottom line is yes, but it's first you have to be intentional to actually want to do it and then contact Cassie. So
yes. Yeah. No, I've been developing a lot of different guidance. I think on my website, clinicallysustainable.org, I've got like a little, like here's kind of a test run of where you're at, but we're also going to launch, we're trying to publish this little paper that's like for you as an individual, if you're a clinician and you're interested in this work, like here's different ways to think about sustainability broadly, not necessarily even just within your hospital system. But if you want to engage as an individual in sustainability work, like here's a way to think about it and to triage it, to find the best fit for you, because sustainability, like this, addressing climate change, all these environmental issues require that everything everywhere changes. Like the way we've been doing everything does not work and we all have to change. And so that means every one of us in every industry from every walk of life have things that we can do to make those shifts happen. So, even if you're like the lowliest of low on the power structure within your institution, there are things that you can do that will still help. But I like to try to move away from that individual space. This is kind of what I do generically with my my Substack, my blog, and then also in my podcast, So Climatic, is moving away from that individual feeling. Like that's what companies want you to do. We can have a whole podcast on that kind of issue.
We'll have a different episode on that. I have many thoughts on it.
But it's well documented that fossil fuel industry has made an individualized carbon footprint to make you feel guilty and to make you feel overwhelmed so you don't do anything, and so that they can keep on polluting and doing whatever the heck they're doing without getting that scrutiny. So I like to try to move us away from that individuality, like, what are you going to do, to more like, how do you leverage your influence and your power to make more institutional type changes? And so if you're a clinician, you're not alone. And that's really, really important in any sustainability work. Like, you're not alone, and you have to find your group to help support you and build you up and provide resources and whatnot. There are so many groups that are working on healthcare sustainability. To name a few, there's Healthcare Without Harm and Practice Green Health. Those are two orgs that work more at the healthcare system level, and they have healthcare systems who are members. And if you're a clinician, maybe your healthcare system is a member and you can get access to their resources, which will help give you ideas and things. Your healthcare system might have a green team or a sustainability coordinator or something like that you can get engaged with. Same with your company, right? Your company may have some sustainability folks working on this, and it's always nice to get in touch, even with a really large company, like say, hey, I'm curious about this. I want to learn more. If you are not part of those orgs, or your healthcare system is maybe not the most forward thinking, there are groups outside of your health system that might be nice to partner with. There's the Medical Society Consortium for Climate and Health. It's a mouthful. But they support individual clinicians in how to write op-eds, how to chat with your representatives, right? To leverage that clinician voice. Nurses and doctors are one of the most trusted professions year upon year when they survey this stuff in the US. And so if you are a doctor or nurse, you have some power in influencing climate change just by talking about it with your patients, or writing an op-ed to your local newspaper if it exists, or talking to your representatives, right? You have some credibility just by being a doctor and seeing the effects of climate change on your patients. But yeah, there's a lot of those kinds of things that you can do. I mentioned EYE Sustain. So if you're like an ophthalmologist, there's a group that just works on sustainability in the ophthalmology space, and they're really wonderful and active. And there's actually a lot of different groups like that for different specialties. There's radiologists for a sustainable future, right? So you can get engaged within your specialty and try to get your specialty on board with this, because those societies that you might belong to as a professional have their own leveraging power. So these ophthalmic societies that I'm working with, they have a manufacturing group that they meet with at their annual meeting to say, hey, we want you to do X, Y, and Z. Like, how can we work together on this? And they talk to the representatives at the FDA to say, like, write us an op-ed that says it's not a single-use thing unless it says single-use on it. And that happened. That's what they did. They got the guy from the FDA to write that. So like there's different power that you can leverage depending on who you're connected to and what your own, station is. And you should leverage that power to the best of your ability, because that's how you get that broader reach, and that's how you get better adoption and support for the individuals who really want to make a change. So that's what I'd say.
This is wonderful. This has been such an insightful conversation. Thank you very much. And for those who want to learn more about your work, they want to follow you or contact you to get you to help them become more sustainable, how can they get in touch with you?
So my consulting business is called Clinically Sustainable. And so you probably just Google that. I don't think there's many of us out there, but clinicallysustainable.org is my website. And so you can email me, Cassandra@clinicallysustainable.org. I do have a Substack, which I call Love and Guilt in the Anthropocene. So you can look that up. You can contact me through LinkedIn. I'm kind of everywhere at the moment, but those are probably the best approaches.
Wonderful, wonderful. And thank you very much for sharing your expertise and shedding more light into this very important field that requires sustainability. We need to make it. All industries require it, but here in the healthcare systems, it's very critical. And there's a lot of room for improvement, as you have already shared.
So much room.
Yeah. And I have one more question that I ask all my guests. Drum roll.
This is the tough one.
Yes. If you had one or two or three people to have dinner with, who would they be with, and why? And could be dead or alive. No limits here.
Yeah, this has been a tough one. I've been thinking about this because I know you had it in there. And yeah, it's definitely hard for me to answer because there's so many people I would love to sit down with. And I think I kind of mentioned to you, like, I'm not sure who I'd want to be like eating in front of either.
Well, it could just be a tea, coffee, water, or just chat, like just like this.
Yeah, I think I'm forgetting his name now. Sure not the Patagonia, like the former CEO.
Oh, yes.
I cannot say Yvonne Chouinard.
Yeah.
Is that how you say it? I would love to sit down with him or some of the other like early founders from Patagonia, because I think what they've done is really remarkable in the industry, and just to be able to like pick their brains on how they converted, their environmental ethos and the understanding of essentially the damage that they were causing to this thing that they loved and was a crucial part of their business. How they really started integrating that into their business, but expanding it beyond their own walls. Like, I think it would be so much fun to sit down with that team and to have a chat with them about like, how did you get the whole industry to start working on this, right?
Yeah.
How did you build partnerships with like Walmart and like some of these other groups to really get them moving on that front? Because I think they've done some really remarkable work, just rethinking how a company can work. Like, they still have their market share. They're still really like effective and have the customer loyalty and whatnot, but like they're able to not, I don't say not care about their business. They care about their business, but it's not just about the immediate financial gains. Like, basically, how do you break through that capitalistic model that's so prevalent everywhere, even in healthcare, where you would think it would be easier to overcome that, like, we're only in it for the money, but it is actually really challenging to get through that. Like, how do you get these different groups who are, ostensibly enemies, to work together for a bigger goal here that benefits all of us? And, it's just not many people can see that it benefits us all. Anyway, I think that would probably be my initial dinner guest collection.
That is wonderful. That is a great pick. I mean, all picks are great, but I really like this pick. So, yeah. Well, thank you so much for being in the program. Again, this conversation was so insightful, and thank you for sharing your expertise and all your knowledge and experience with us. And
thank you so much for having me on. It's been fun chatting.
It's awesome. And we'll have you back. I think there's so many other topics that we can talk about. We can go all day. So
that is very true.
Well, thank you very much, Cassie. And listeners, thank you very much for tuning in. And we will see you next time.